Come on. So we are talking about sensation, somatosensation. So we're not talking vision, vision, vestibular, taste, all that kind of stuff. Those are all considered special sensory things. So we're talking about just somatosensation, sensation from the body today. All the skin in our musculoskeletal system, muscles, joints, ligaments, tendons, all that stuff have ability to sense things. So it's important. Allows us to investigate the world, move accurately, minimize injuries. There's actually some people born with some unique deficit of their thalamus, the ventroposterolateral part of the thalamus, where they actually don't have any pain. They receive no pain signals. You think that'd be cool, that'd be a blessing, right, to have no pain whatsoever. But those people often die in their early 20s to mid 30s is the common range because they end up injuring themselves so severely over time, the accumulated trauma or an infection that they die from, or their body can't sense pain, so it continues to injure itself, and so they'll die from one of the sequelae or events from that. So yeah, pain is good. That's what I try to tell my kids to a point, so it tells you something for sure. We're going to kind of divide somatosensation into two broad things. Superficial sensation, the kind of sensation you feel more on your skin or the surface of your body, okay? Things like pain, temperature, touch, superficial pressure, vibration, touch, okay? Then we'll talk about also musculoskeletal sensations. Some people call it deep sensations. So those would be things, we can feel deep types of pain versus superficial pain, that deep aching type of pain. Also proprioception, okay, both conscious and unconscious, but we don't know that we can't sense the unconscious proprioception, but we have unconscious proprioception and conscious proprioception. Stretch, tension, position, deep pressure and vibration. Those are what we mean by more musculoskeletal types of sensations. So how does this process of somatosensation occur? So we have a general little graph here on the left, and then a more specific. So general would be some type of stimulus occurs, okay? It causes a receptor to be activated, If it's a mechanoreceptor, it might deform some mechanoreceptor gated, modality, not modality, but mechanical stretch related, modality gated, sodium channel to open and cause an action potential that goes up a peripheral nerve, then goes into your central nervous system, into the spinal cord, and then up to a final destination, whether that be cerebellum, cerebral cortex somewhere. Okay, so that's the general. Then a more specific example would be, here's an example of pain. You get a pinprick on the arm. A pinprick will typically, if it elicits pain, is going to be stimulating a free nerve ending. That's going to cause that. It's going to go up a peripheral nerve, and there's a certain classification system we use to describe the types of peripheral nerves, and this would be an A delta fiber, which is a fast pain fiber. It's going to then ascend in a pathway in the central nervous system. In this case, it's going to be part of the anterolateral system, which more specifically, the fast pain would be the spinothalamic tract, which is part of this whole anterolateral system. And it's going to end up going to the thalamus, in the VPL, the ventroposterolateral part of the thalamus, and then eventually up to the postcentral gyrus in the cerebral cortex. We'll go all through this in detail, but that would be more specifically how this would occur for a given sensation, in this case pain. So here's this lovely little one-pager that kind of summarizes everything in one shot as far as somatosensation. And so we start at the top of the chart here, and you'll notice you have to stimulate some type of receptor. You got to stimulate some type of receptor to get a stimulus, so you can feel what's going on here. Receptors are generally classified into three broad categories. They're either a mechanoreceptor, a chemoreceptor, or a thermoreceptor. You'll notice that we have a lot of specialized mechanoreceptors. Depending on where they're located, what their role is, and what part of the skin, body, muscles, ligaments, tendons, those kind of things. So you have these specialized mechanical receptors that respond to tension, pressure, touch, vibration, those kind of things. So those are all these specialized mechanoreceptors. you'll notice that if it's a chemoreceptor or a thermoreceptor, there's only one thing it can be. It's a free nerve ending right here. Free nerve endings are nice. Free nerve endings are not necessarily nice, but they're unique in that they can be stimulated by almost anything. They can be stimulated by mechanical stimulation. They can be stimulated by thermostimulation or chemo or chemicals landing on them. Most free nerve endings, though, have a pretty high threshold. You have to do something to it at a higher level to get it to do its thing. Because free nerve endings are very commonly eliciting things like pain and inflammation and so forth. So free nerve endings, you have to push them a little bit harder to get them to actually send their signal. Okay, so that's all that's showing you right there. Then once you've stimulated the receptor, whatever that peripheral receptor is, once you've stimulated so it actually creates an action potential, it's going to be carried on an axon back, the peripheral axon, to get to the spinal cord. This is called the first order neuron we're on right now. So it's this receptor and its axon going back to the spinal cord, and it's going to be carried on a type or a classification of an axon. We'll go into all these, but this is the classification system we're going to use. 1A, 1B, 2, A beta, A gamma, and A delta, sorry. A beta, A delta, and C fibers. Those are the types of peripheral axon classifications, but those might be running in your median nerve or in your, radial nerve or whatever. Those are running in nerves, and they're just that you classify them based on their diameter and their myelination. These peripheral sensory axons are given a classification name. Okay. Then once you get into the central, these are the sensory pathways are in your CNS. Once you've delivered the message into the spinal cord, now you're in the central nervous system. So all this out here is all peripheral, happening in the periphery. Then once you get in the CNS, we can then talk about the types of sensations. So we have sensation that's considered, we call fine touch, conscious proprioception. These are things, this is touch that gives you the ability to discriminate texture and feel and nuance and also know where your body is in space consciously. Like I can say, yeah, my elbow's bent about 90 degrees right now, and I can tell you that. Or I can tell I'm standing upright right now and there's pressure on the bottom of my feet. That's the kind of stuff that's carried on this called fine touch, conscious proprioceptive system, which is really called the dorsal column medial lemniscal system. Okay, and we'll talk about why we call it a system and this dorsal column medial meniscal tract. And then we also have a big number of tracks. We actually have 4 pathways we're going to talk about. Well, so that has 2 pathways. You'll notice that when we get to some of these, you have the dorsal column medial meniscal system for the body, and then we have a kind of an equivalent system for the head and face. Okay, so the trigeminal pathway for the head, it's just called the trigeminal pathway. The dorsal column medial meniscal systems for the body. Okay, then we have the unconscious proprioception. This is the spinal cerebellar system. These are all tracks that are coming into your spinal cord, going up and ending in your cerebellum. They never make it to your cerebrum. So you're not consciously aware of these. These do not contribute to conscious proprioception or conscious awareness. They contribute to proprioception and making automatic adjustments to posture and so forth, but it's all done in the background. Okay, those are collectively the spinal cerebellar tracts, and we have 4 of those we'll talk about. Okay, so that's these 4 here. Some for the upper body, some for the lower body, some that are internal feedback pathways that are only just within the spinal cord itself, and we'll talk about those. And then lastly, we have we'll call the anterolateral system, which is for coarse touch, just really crude touch, like you can actually like itch and tickle and like, yeah, I can feel my arm here, but I can't tell you exactly where you're poking me. That's coarse touch versus this is fine touch up here on the dorsal column medial meniscal system. This is just kind of coarse touch, and then pain and temperature. Those are all carried on this thing called the anterolateral system, and it runs a little more anterior and lateral in your spinal cord. That's why it's called the anterolateral system. This collective group of pathways and information, and then we can divide that into what's called then a fast localized pain type of response or sensation, or a slow aching divergent pathways. And then we have a spinothalamic tract that's for the body. That's fast pain from the body and fast pain and temperature, and also an equivalent one for the head called the trigeminothalamic tract. And then we have these three tracks or pathways here that are the slow aching pathways, or divergent, because once they get up into your cerebral cortex, they diverge and they go to like your limbic system and other regions of your cerebrum to give you that like emotional responses to pain, you know, drive your fear responses, or to get out of that bad situation because you just are harming your body right now and you're feeling pain and discomfort and so forth. So those are the divergent pathways. So in all, we're going to be going through 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 different pathways that make up collectively this whole these systems that carry pain. So we are going to start at the peripheral sensor and work our way back to the spinal cord, then finally up the spinal cord, then into the wherever it ends, cerebellum, cerebrum, brainstem. Some of these end in the brainstem, just right in the brainstem tract. So, as I mentioned, sensory receptors, we have a couple of different main categories: mechanoreceptors, chemoreceptors, and thermoreceptors. Those are the three main categories of types of sensory receptors. Okay. These receptors in general can also be either considered a tonic receptor or a phasic receptor. Okay. So a tonic receptor are ones that respond as long as you stimulate it and maintain the stimulus. They'll continue to bang out and send a signal, boom, 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 and keep you aware of that sensation. Okay, that's a tonic receptor. Phasic receptors, when you initially push on or do something to them, they give a nice big response, but if you maintain the stimulus, the response goes down very quickly. It may not go all the way back to baseline, but it goes down pretty quickly. And then when you release the stimulus, you might get another spike that tells you the stimulus is now being removed. Okay, so those are phasic receptors. So they have both tonic and phasic receptors. And this gives you a little idea of what that might look like. Here is the stimulus. You provide some type, the stimulus strength here, you push a certain amount on the skin. This is for a tonic receptor. So if I push on my skin right here, I can feel that. And if I maintain that pressure and close my eyes and think about it, I can still feel that pressure, right? So there's obviously some tonic receptors there in this region in my skin. And so you get an initial spike that's even a little bit, you know, higher than the baseline that it'll eventually end up at, and that'll signal the application of the pressure, okay? And then it'll stabilize. It might drop a little bit, but it'll maintain a certain level of firing above baseline to tell you there's still pressure going on right there. So like even now, if you're sitting there in your chair, you just think about the sensation you're feeling on your back and your butt. Even though you forgot about it for when you're just sitting there, now if you think about it, you can still feel it, right? So those are the tonic receptors that are always telling you a little bit about what's going on, your pressure on your, and that's also going to make you like shift when you start to have pain and so forth, so you don't get a pressure sore, you know, sitting here for a 3-hour lecture. So those are the slow adapting receptors, the tonic receptors. Then we also have some rapidly adapting ones that they throw a really big spike when you initially put the stimulus, but if you maintain the stimulus, they go back to nearly baseline, not always to full baseline. And then when you remove the stimulus, you might get another spike going the opposite direction, but also that's a signal that the stimulus is being removed, okay? And phasic receptors are more important, especially for dynamic movement. Like when you first plop down on your chair, you'll get a big burst of phasic receptors that'll, you know, you'll get that initial sensation that'll give you, and then your tonic receptors, those ones will go quiet. Your phasics will go quiet, but your tonics will be in the background and fiery. So if you think about it, oh yeah, I do feel that pressure. But then when you go to get up, you fire those phasics, plus you also fire the other ones as well a little bit. So the stimulus off, but you'll kind of get this ability to sense this dynamic turning on and off the sensor. Especially the phasics are also especially important for rapid pendular movements. So when you're like walking or you're doing an activity where you're doing fast starts and stops of movements, those phasic receptors turning on and off give you timing, knowing when things are occurring and those kind of things. So phasic receptors are more important for dynamic movements, where tonic receptors are more important for static postures and positions and so forth. Make sense? Now let's talk about the receptors and then the axon that they're going to send their signal up, and talk a little bit about the classification. So we have these peripheral neurons, right? Somatosensory peripheral neurons. So you have the receptor out there in the periphery, in the skin, ligament, tendon, muscle, and then it's got an axon. That axon goes all the way to the spinal cord. Okay, so if I've got a little Pacinian corpuscle in my toe, that axon goes all the way up my sciatic nerve, all the way up into my L1, L2 area, near that cauda equina. So that's a pretty long axon from there, and that's a peripheral axon that's in a nerve, in a bundle, with a bunch of other nerves that are coming up from other locations at the same time. But those are those afferent nerve fibers acquiring afferents, bringing information towards it. The cell bodies for most peripheral nerves are located outside the spinal cord. This is the cell bodies up in that dorsal root ganglion, or if it's from your head and neck, it's in the cranial nerve ganglion. Like the trigeminal nerve has a big ganglion just outside the pons where the cell bodies are for the trigeminal nerve that brings a lot of facial sensation in. From your head and neck, that cell body is up there, okay? They are typically classified according to the axon diameter is the main thing that they use for classification. So going from slowest to fastest, in this case, in your Lundy-Ekman book, this is in meters per second. So C fibers are your slow pain fibers, okay? So if pain is coming up a C fiber, it's moving pretty slow. It's a whole meter per second. And for some of you who have long legs, that's a whole second just to get, that's a meter, maybe from your toe up to your back, a whole 1/1000 before it even gets to your spinal cord, and then once it's in your spinal cord. But that's typically associated with more of those slow aching pathways. So you've already taken your hand off the hot stove, and then afterwards, now you start getting this pounding, pulsing pain that's coming from C fibers. The A delta fibers, the fast pain fibers, allowed you to take the hand off really quickly, but the C fibers, they're a little bit delayed. They come on later and then give you more pain later. So the A delta fibers here, those are ones that they're a little more, the bigger diameter and a little more myelinated than the C fibers. Okay, the A delta fibers are kind of like medium myelinated. The C fibers are considered unmyelinated fibers. And so they'll carry it at 45 meters per second. So that's a lot faster. So that's going to happen a lot faster. That allows you to get that hand off the stove really quickly once you feel that pain get to your brain and you're already removing your hand. Okay. And then they're classified. Then you have the twos or the A betas. They're both about 90 meters per second. Then you have the 1Bs, which are 120, and then the 1A is 130. So you'll see when we get to the muscle spindle, we have 1As, 1Bs, and 2s. They're all really fast. Once you get above 45, you're talking double the speed here. These are all associated with proprioception. These are all associated with having to make rapid postural adjustments, knowing where your body is in space. That thing has to be so fast to make corrections so you're not falling over, you're not losing your balance, you're not making misdirected movements. You have to get really fast feedback to make corrections of movement on the fly. Does that make sense? So even faster than pain. It's even more important for proprioception, it seems like, than pain because of what it's trying to do and how fast things have to happen. So those are much bigger diameter axons. This is just showing you we're still talking periphery here. So here's the sensory receptor. This case looks like a Pacinian corpuscle, the way it's shaped there. It's peripheral axon coming in through. Here's the spinal nerve. This could have been coming from your foot and up the sciatic nerve and eventually into the spinal nerve. And then this is the peripheral axon. Here's your cell body in the dorsal root ganglion. Then this is the central axon that goes through the dorsal root. This is now the dorsal root, and these are the little rootlets that are, go into the back part of your spinal cord here. So it goes in through these little rootlets into the dorsal horn. Okay, or it may not be this would not be going to the dorsal horn because this is a proprioceptive thing. It's actually going to go right into these are the two dorsal columns back here. It's going to go into one of these dorsal columns. So it's not, if it's pain and temperature, it's going to go to dorsal horn, but if it's proprioceptions, go right in the dorsal columns back there. And then this is what we're going to be. It's either this is a Pacinian corpuscle, so it's going to be a pretty fast one. You know, it's going to be probably a type 2 fiber or something like that, or A beta type 2 fiber for, you know, types of classification of the axon. Let's talk also about the concept of receptive fields. When we talk about especially superficial sensation, skin sensation, it's the area of skin innervated by one neuron, okay? They tend to be, your receptive fields tend to be smaller, more distally, like your tips of your fingers, your toes, even your lips and tongue. You have these very small receptive fields. When you get up more proximally into your trunk, you know, upper arms, you have these large peripheral fields, receptive fields. And this is how we get two-point discrimination. So if you look at this, here is this yellow area is the area of skin supplied by this single neuron, right? So here's a single neuron, it branches out, it has nerve endings, it has receptors, and it gives you the information from that single receptive field. And here's another neuron coming in, and it also supplies a certain amount of your skin surface, and there's often a little bit of overlap between these receptive fields, okay? If you think about it, if you have one nerve that supplies a really big area of receptive field, and you take something with 2 points and you put it down in that receptive field, if both of those points fall within that same receptive field, because it's only going on one neuron, it perceives it as one stimulus, and it can't discriminate that two things actually touch at the same time. Does that make sense? But if you have smaller receptive fields, a lot of little ones, when you put something with 2 points, or you're trying to feel the fine edge of a textured item that has lots of little ridges or bumps, there's more of a chance that those little ridges or bumps or those 2 points are going to fall in more than one receptive field. So if you like in this example here, this, because the 2 points fall in two separate receptive fields, you're going to receive two separate signals to your brain. And because you receive those two separate signals, you're going to say, that's two separate points that touched me. If you can see here when they did the stimulus, when they poked it there, that both of those fell in that same receptive field. And that's only going to be recognized as one stimulus or 1 point. So basically, you need to understand that lots of small little receptive fields are going to give you more discriminative information. It's going to allow you to feel those 2 points very close together. So if the smaller the receptive field, the more closely those 2 points can be together, they're more likely to happen to get into two separate receptive fields. Okay? The larger the receptive fields, like in your back and so forth, you got to put a caliper that's like this far apart for them to tell that you've actually got two separate things touching you at the same time. Now you do have to, like when you're doing the test for this, you have to touch those 2 points at the exact same moment. If you go boom, boom, even if they both land in the same receptive field, you'll get two separate action potentials. Does that make sense? So you got to be careful if you're doing this testing. Like most of this is done by occupational therapists to look at fine sensation for manipulating objects and doing home tasks and things like that. They'll put these two. We'll do it in a little quick lab activity maybe on Wednesday, where we have 2-point discriminators that are measured out by millimeters how far apart. You got to touch them down at the exact same moment. If you go boom, boom, they'll sense it as one, even if it falls in the same receptive field. And you're trying to just determine what's their threshold at any given location. And most of the time it's done on fingertips. It's very rarely done on other parts of the body, but fingertips or toes, that kind of thing, as you do this 2-point discrimination. This is just showing you the different threshold levels for 2-point discrimination in different regions. So this is the relative, I don't know this would probably be about 3 millimeters. Most people can feel about 3 or 4 millimeters of difference at the index finger. Similar at the thumb, just a little bit wider at the thumb. And then when you start getting to the forearm, and here's the back, and they're very similar. You have to get a caliper that's 42 millimeters apart. I mean, that's 42 millimeters, might be something like that, apart, in order for them to consistently say, oh, that's 2 points you're touching me with. Because the receptive fields are really large. You only have one neuron supplying a pretty big area of skin. It's just a matter of conservation. Your body doesn't need all that information from those regions. You're not manipulating things with your forearm. So why waste valuable cortical space for a part of your skin? You don't really need to have that discriminative ability. Let's use it at the fingertips. Let's have lots of little neurons going there and take up more real estate in your cerebral cortex for your hand to gather that really fine discriminative information and make sense of your world. Calf is really, back of your calf is even more than your back. So you got to try that sometime, is when we get the little 2-point discriminators out, compare your fingertip to your calf and see how wide you have to get. I don't know that the discriminators we have go wide enough for you to be able to get 2-point on your calf. You might have to get a big, like, safety pin or something and really stretch it out to kind of touch it to get that. So we're still on this superficial sensation. And let's just talk about and define some of these types of superficial sensations or skin sensations. So fine touch is one of the types of sensations that you'll feel. It's discriminative in nature. You're making sense of the world because of this. When you fine touch is when we do this. If we're touching somebody and we taught you guys the cotton ball, like, can you just tell I'm touching with the cotton ball? That's coarse touch. You can turn it into a fine touch test by saying, let's say I'm touching your forearm, and you say, and they're just responding yes every time you touch. That's coarse touch. But if you say, you touch it and you say, now point to exactly where I touched you, boom, that's fine touch. So you want to touch both. Coarse touch doesn't tell you a lot, but fine touch then really tells you if these dorsal column tracts, medial meniscal system is working okay. And so then you go. So the cotton ball just on regions is a real quick screen. If they can't feel the cotton ball, why bother even testing fine touch? But if I touch the cotton ball and they're saying yes, 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 and I'm like, okay, so they have a basic level of sensation. Now point to where I just touched you. Which part of your body did I just touch? It's probably not good to some just they could say left arm probably or something like that, but it's better just to have them point to it, because they don't have the terminology to describe posterior lateral surface of the left arm, the distal 2/3. They just tell them, point to me where I just touched you, and within a reason. But back of your arm, those fields are pretty big. If they get within an inch or two, you're pretty good. Where they touched you. That's fine touch, and those are using specialized receptors, things like Meissner's corpuscles, Pacinian corpuscles, Ruffini endings, Merkel's discs, hair follicle receptors. These are all mechanoreceptors that do this for fine touch. Okay, so fine touch are mechanoreceptors that are typically specialized. The more specialized that ending, the more discrete information it gives you. Coarse touch is this poorly localized tickle, itch, general sensation of superficial skin sensation. This is free nerve endings do this, okay? And this is free nerve endings acting as mechanoreceptors. Free nerve endings are not specialized. They're the jack of all trades. They don't give you a lot of they give you some information, but they don't give you real fine-tuned information. Then we have pain. Pain is a free nerve ending, okay? They're considered a nociceptor when they transmit pain or cause a pain stimulus. And it can be mechanoreceptors. It can be a free nerve ending that's a mechanical. It can act as a mechanical receptor if you exceed a certain threshold of stretch or tension on that free nerve ending. That knows it's going to be potentially damaging to the skin or tissue around it. That causes or triggers. So that free nerve ending that was acting as kind of a coarse touch, or an itch or tickle, can become a pain once you exceed a certain threshold with it. You stretch it too much, you push on it too much. Now it sends a nociceptive signal. Now it becomes a pain receptor. You can also, it can be stimulated by thermo. So the free nerve ending can also detect temperature, but then you exceed a certain threshold and that all of a sudden becomes nociceptive or painful. If it gets too cold or too hot, then it tells you about cold and hot, but once you exceed a threshold, now it starts sending a pain signal saying that's going to be potentially damaging to my tissue. Then chemical. If you have any kind of, you have tissue damage around an area, your cells are releasing bradykinin and histamine in the area, they're going to go over to free nerve endings and say, we've got problems over here, we've got damaged tissue nearby, let's get free nerve endings to ramp up their sensitivity and start transmitting pain signals because we need to protect this area right now. So that's when we have chemical messengers from cells in response to damage locally or nearby that'll stimulate those free nerve endings to create nociceptive signals. And then we have just pure temperature, which without transmitting pain. That's the free nerve endings as well. Yeah.
What would the free or peripheral receptors be for unconscious proprioception?
They're actually the same. A lot of the same for the fine touch. Also, some of those carry information for unconscious proprioception. That's a good question. So, in, in most of the unconscious proprioception is really actually, it's not, actually, this is superficial sensation. Most of the unconscious proprioception is carried by the ones that are from the muscles, ligaments, tendons, and joints, which have similar specialized types of endings and so forth. We'll get into like GTO, Golgi tendon organ, muscle spindles. Then you also have some of the Ruffini endings and some of the Merkel's things that are similar in the joints and ligaments and tendons to the superficial receptors. Okay. So this is just showing you through a cross section of skin, because we're talking superficial sensation here, and you just see where some of these tend to be located. When you're talking about hairy skin, so skin that typically has hair on it, these are the receptors that tend to be there. You get a little more higher preponderance of Merkel discs right on that epidermal layer there, and then you even have the little hair follicles that have this is called a paratracheal ending that wraps around each hair follicle, and when the hair follicle is deformed will send a signal about which direction things are brushing on you and those kind of things. And then here's some Ruffini endings that tend to be a little more prevalent in hairy skin. When you get into hairless skin, lips, tongue, face areas, you have more Meissner corpuscles, and it's just the subdermal layer. You have some more free nerve endings. You have free nerve endings everywhere. So, and a little more preponderance of Pacinian corpuscles. So, this is a table I would know. It's a good table that summarizes, not out of your book, it's just one I found. It gives you on the left the receptor type, some general anatomical characteristics of that receptor, the associated axons that it sends its signals on, the classification of the axon by diameter, the general location where these are, its main functions, its rate of adaptation, whether it's slow adapting. So tonic receptors are typically also referred to as slow adapting, and phasic receptors are rapid adapting because they rapidly adapt to that stimulus. And then the threshold of activation. How much do you have to mess with it before it sends a signal? Now, I like to group things in my head. So as opposed to memorizing everything in detail, grouping things like when I look at this chart, I see that, here's a whole group that all use that A beta fiber for their classification. So if I know that most of these things use A beta fibers, except for muscle spindles, they're 1As and 2s, and Golgi tendon organs are 1Bs. And then we also, free nerve endings, that's pain and temperature, is the Cs and A deltas. And so I can kind of, that grouping can be helpful possibly for memorizing this stuff, okay? Also, looking here at the threshold of activation, this is an easy one. Free nerve endings are high threshold of activation because those are pain that they're going to stimulate in that case for pain endings, and everything else is low threshold. Everything else is very sensitive to providing information about what's going on. So anyway, just kind of I would be aware of that table and feel good about know the general makeup of that table. Still on superficial sensation, still conceptual, different things associated with superficial sensation. Dermatomes, that's area of skin innervated by a single spinal nerve. The ones you really want to pay attention to that are most clinically relevant are that C5 to C8, C5 to C7, and C8, I guess, because it goes down sensation. C8 is more relevant for motor function for the hand and fingers. But then L4 to S2. Those are the regions where most of your patients are going to have problems if they have neck problems or back problems. All the rest is just thoracic. All the rest is thoracic, and it's all in here. And you're not noticing if somebody's got a thoracic level deficit of a spinal nerve, they might have some pain, but it's just going to be in a area that wraps around their body that's corresponding to that level. So really, it's what's going on in the upper and lower body that you want to be feeling like you know a little bit more about. And then we have peripheral cutaneous nerves as well, right? So the dermatomes, but then we have branches. Once your nerve branches to specific regions of your skin, you have these peripheral cutaneous nerve distributions. So like the median, ulnar, and radial in your hand is really important to know. And then femoral and superficial perineal for your lower leg, you know, is kind of ones that would be clinically probably useful to know. Um, I found this crazy book. I think I still have it in my office. All these black and white drawings, and and this is how they showed the dermatomes in this particular book. And so, she's hiding some of the dermatomes. It's not the best representation of dermatomes here, but I just thought it just cracked me up that they had this picture in there. I think it was from the 1960s or something like that. So, yeah, it's like, come on, we can't see them all. Show us the dermatomes here. So here's this is this is our generic avatar here, that androgynous avatar here. So that, as out of your book, that shows you on one side of the body, shows you kind of the dermatonal breakdown, then the other side more the peripheral cutaneous as the nerves finally branch and supply. So if you damage the nerve root, actually at the root, you'll get a loss of sensation or problems with sensation in a dermatonal pattern. If you damage it out in the periphery, after it branches, it makes its final branch, you're going to get more of the peripheral nerve distribution types of loss, right? Okay. So it's just important to kind of understand that difference. I have a nerve root problem versus a peripheral nerve. Well, your nerve root is still kind of part of your peripheral nervous system, but the peripheral nerve, once it's made its final branching, it's going to supply its little certain region of skin, which is different than the dermatome, the dermatome is actually innervating multiple different final branches of nerves and to give you a different characteristic pattern of sensory loss, okay, or sensory problems. Remember, dermatomes overlap too. So it does not look like that in the real world. There's overlap, these dermatomes. So when you're testing, it can sometimes feel a little hard. But most of the time a patient will, if they say, I get pain radiating here, or I feel numb here, if it's going like this all the way down their arm like this, I'm thinking, oh, is that C6, coming down, or C5 coming down? Or, or if they say, it's just right here in my thumb, oh, is that ulnar nerve or radial nerve? Is it median nerve? Or, I'm thinking more that way, so just versus dermatonal versus peripheral nerve distributions. Let's talk musculoskeletal sensation for a few minutes. We'll take a break right at the top of the hour here. So that was all superficial sensation. Now we're moving into musculoskeletal, muscles, ligaments, tendons, joints, okay? And we're going to start with one of the most important ones, is the muscle spindle, okay? So the muscle spindle is embedded in all skeletal muscle. It's going to detect how long your muscle is at any given moment, but also how quickly the length is changing at any given moment, okay? If you remember back to, I don't know, did you guys talk about this in phys at all, or with Dr. Renner a little bit, but, oops, I did not, forgot, sorry about that. Has what we call intrafusal fibers. The muscle spindle is fusiform in nature. Fusiform is tapered at both ends, and this little capsule, this receptor, this muscle spindle is embedded within your muscle, right? So you've got this fusiform little capsular, enclosed with these fibers in it, these little fibers in it, these muscle fibers, and they're called interfusal muscle fibers, where your skeletal muscles are called extrafusal muscle fibers because they're outside the muscle spindle, so they're the extrafusal fibers. You have two primary types of muscle fibers in your muscle spindle. You have the nuclear bag fibers and the nuclear chain fibers. The nuclear bag, they're kind of plumped up in the middle like a little bag of nuclei. There's a bunch of nuclei right in the middle, kind of bagged up. That's how I kind of remember a nuclear bag. Then the nuclear chain fibers are more stretched out, and the nuclei of those cells are lined up in a single file, and it's a little narrower. Okay, so those are the nuclear bag, nuclear chain fibers. The muscle spindle has afferent fibers, These are axons that are taking information to back to your spinal cord. That's going to go, most of this information is going to go to your cerebellum. But these afferent fibers, these are taking information from the muscle spindle to send it back to your spinal cord. And there's two ones. There's a primary afferent fiber and a secondary afferent fiber. The primary afferent fibers are also known as the annulospiral fibers, and they are classified as 1A, the fastest afferent fibers known. 130, 150 meters per second that they're sending this information back to the cerebellum. They need to get there fast because you need to make corrections on the fly to correct improper movements and those kind of things. You have both phasic and tonic primary nerve endings. So it's interesting that this one has both a phasic component that can sense rapid changes in muscle length, but also a tonic component that can sense what the new resting muscle length is once you get to that new length and stay on. Does that make sense? So it's both phasic and tonic. The secondary afferent fibers, also known as the flower spray fibers, they send their signals on type 2 fibers, which are a little slower, maybe closer to 90 to 100 meters per second. They are just giving tonic information about the whatever new resting length of your muscle or current resting length tension in the muscle. Okay? Now, the muscle spindle is a little unique as a receptor because it also has efferent nerve endings. It not only sends signals back, it's not only a receptor, but it's a receptor that can adjust or fine-tune its sensitivity. And so the way you fine-tune or adjust the sensitivity of your muscle spindle is you adjust the length of it. Okay? And the way you can adjust the length of it, one of the ways, is through the efferent nerve fibers. So you have these little motor nerves that go to the little ends of your muscle spindle fibers. These are little muscle fibers, and you can contract them to make your muscle spindle shorten if you need to adapt it to a shorter length. So that's the efferent nerve. And we'll get into why it has to do that at a future. I don't think we'll get into this lecture. I think we actually do that in the motor system. We'll talk about how its role it plays. So right now we're really focusing on the afferent part of the muscle spindle, the sensory part of the muscle spindle. But the muscle spindle does have this ability to adjust its length through some motor signals going to the ends of it to make it tighten up a little bit if we need to maintain its sensitivity and maintain its ability to stretch. So here's our muscle spindle, this fusiform structure in the middle here. So fusiform, tapered on both ends. These are little muscle fibers in here, and these guys here, these are the gamma motor neurons. These are the motor neurons going to the ends to help contract that muscle spindle. As your muscle is contracting, the muscle spindle also contracts. So when you send a signal to your muscle to contract, your muscle spindle contracts with it. So it maintains the same proportional length to the muscle at all times. It's a way of setting the gain or the sensitivity, which we'll get to when we get to the motor system. And then here's your nuclear bag fibers here. This one mainly clumped towards the middle a little bit, and then we have more of our nuclear chain fibers here, where you see the cell bodies just lined up in a line. And then we have these blue fibers are afferent fibers. Those are the annulospiral and the primary nerve endings, flower spray and annulospiral. We'll show you this. This is a better picture where we just pull out one nuclear bag fiber and one nuclear chain fiber. Okay. So here's the efferents. These are the gamma motor nerves going to the ends to help contract it when needed to adjust the length. But let's focus on the sensory part of it. So here's our nuclear bag with our bag of nuclei that are all clumped together here and piled up in the middle. And here is our 1A afferent. This is our really, really fast feedback axons sending signals rapidly to the spinal cord that are actually going to go into your cerebellum primarily. Um, this is the annulospiral fiber. See how it spirals and wraps around that nuclear bag? This is also known as the primary nerve ending. Okay. This one is phasic. This branch, this spiral, it's phasic in nature primarily. Okay, this particular branch, and it's detecting velocity of the change in length, how fast your muscle is changing length. The nuclear bag fibers are better at detecting rapid changes in length because they're kind of clumped up in the middle, and they actually have a little more ability to stretch and deform, and the little cell bodies can move over each other and creates more signals that tell you about what's happening. They already kind of have a little slack in them, so when you pull them and all those cells kind of start to line up, it gives you more of a sense of how fast the muscle is changing its length and gives you a little more burst of information about muscle change in length than does the nuclear chain fibers. The nuclear chain fibers, all those little cell bodies are kind of lined up inside of there all along, and they don't have a lot of ability to move or stretch, so they're just going to create tension. They're not going to be able to give you as much of a sense of change in length because the nuclear bag fibers can really kind of stretch out and the little nuclei can move and give you more of a sense of change in length. This is more of tension that you're going to sense, and that's where we have, this is muscle length, the tonic muscle length. So you also get some information from these annulospiral fibers that are wrapping around the nuclear chain. So you're going to get some really fast, rapid information about the new tension in the muscle. The nuclear bag's telling you about how fast its length is changing, where the nuclear chain fibers are giving you a little more about the tension in the muscle, okay, at any given moment. And then we also have, this is the flower spray. They kind of, sprays out. They show them wrapping around a little bit here, but this is the secondary endings. Okay, this was the primary endings we just talked about. Now this is the secondary endings, and this is carried on the type 2 fiber, which is a little slower, and it's just going to the nuclear chain fibers. And it's going to give you that tonic, resting length again. About once your muscle's now in that new position, it's just a backup and also contributes to giving you a sense of where that new position and what amount of resting tension in the muscle. Okay? So we're still on the musculoskeletal sensation, and we'll take a break right now before we get to the GTO. Any questions before we break that's fresh? All right. Break sensation. We talked about the muscle spindle. Now we're going to briefly mention the GTO, Golgi tendon organ. It senses tension. It's going to give you, the muscle spindle gives you tension of the muscle. Specifically, those nuclear chain fibers give you more about tension of the muscle. This is giving you tension in the tendon, which is different than the muscle, okay? So it's actually the tendon, there's that musculotendinous junction. There's a junction between your muscle and your tendon. That's where these are embedded in. And it's this there's a little cap. This is maybe just a select region of a tendon. This may not be the whole tendon here that we're seeing here. And then you see the little muscle fibers up here. So this could be a small portion of a quad tendon or something like that. And there's this little encapsulation of these fibers that are within that little region of that musculotendinous junction. So it's sensing tension at the musculotendinous junction. It sends its signal back to the spinal cord and mostly back to the cerebellum. Okay, eventually is where this ends up. This is again mainly contributing to unconscious proprioception via 1B afferents, which are pretty fast. 1A is the fastest, 1B is your second fastest. Okay, so. And we'll get into a little more when we get to motor control. With the motor system, we'll talk about the GTO, what it does. It kind of helps to distribute tension more evenly across the musculotendinous junction, so no one region gets too much stress or pull than the other region. Now we'll talk about joint receptors. So now we're in the joint, okay, in the joint itself. And these respond to mechanical deformation of the capsule, the joint capsule, and the ligaments. Okay, so we're talking about capsule and ligaments here. These are embedded in or around. You'll see some familiar names. So Ruffini, we have Ruffini endings in our skin, but we also have Ruffini endings in our joints, capsules, ligaments. Okay, these are also known as type 1 joint receptor, um, joint receptors. When you read literature and you read things, they'll talk about type 1, type 2, type 3, type 4 joint receptors. Then they have their named, original name things here. So it's kind of good to have a little awareness of both. So when you're reading things that you're understanding that. So Ruffini endings are also known as type 1 joint receptors. They send their information back to the spinal cord via type 2 afferents. So relatively fast, but not the fast, not a 1A or 1B. They tend to be stretched or stimulated during extremes of joint motion. The very end ranges of joint motion is when those tend to get stimulated. Then we have Pacinian endings. Remember, we had Pacinian corpuscles in our skin. We have Pacinian endings in our joint receptors. They're the type 2 receptors. They're also carrying that information back to the spinal cord on type 2 afferents. They are most active during dynamic joint motion. So while the joint is moving, and the more quickly that joint moves, the more those are stimulated, how fast the joint is moving. These types of receptors are speculated in the phenomenon, when somebody pops your neck or snaps your neck, grade 5 manipulation, you fire a bunch of those type 2 joint receptors all at once because you're doing this rapid motion of the joint. Also, you do it to the extreme too. You take it to end range, so you get a rapid burst of the Ruffini's and Pacinians, and they are briefly, when all that information goes back to your spinal cord, they actually then, through interneurons, talk to the anterior horn and the motor neurons that are going back to that same region and briefly tell them to relax, because I'm moving super rapidly towards the end range. Don't interfere with that motion. Just let it happen so we don't hurt ourselves, and you actually get you get that, you feel loosey-goosey, but maybe lasts for like 5 or 10 minutes, and then you might tighten up again. But that's because you've got this, you stimulated all those Ruffini and Pacinian corpuscles all at once, and they dump all that information into that dorsal region of dorsal root of the spinal cord, and they, through interneurons, tell immediately the muscles around the joint to relax a little bit, let that happen, even though it's too late, but it's already happened. But you get this kind of burst phenomena that causes some inhibition of the muscles around the joint briefly. Then we have ligament receptors. These are called type 3 receptors. These are sending information on 1B afferents. They're similar to a GTO. GTOs are in the tendon. Ligament receptors are in the ligaments, okay? But they have a similar kind of role and a similar structure and look to them as a GTO. And then we have the free nerve endings. Free nerve endings are everywhere. You can always count on free nerve endings. They're all through our body, both in the superficial skin, but also joints, all that kind of stuff. And they are for inflammation and pain. They're going to carry that inflammation and pain information. They're called type 4 receptors. And they carry their information on A delta for fast pain and C's for the slow pain, slow achy pain of your joints versus the fast. That's on the C fibers. Okay, that's the free nerve endings. That's just a picture showing you some of the relative locations of all those we just talked about in a knee joint. All right, so we talked about peripheral receptors, superficial sensation, musculoskeletal sensation, and all that kind of stuff, kind of what's happening in the periphery. Now we're going to go into the central nervous system, and we're going to talk about where this information goes up through your spinal cord and then where it ends in your brainstem, cerebellum, or cerebrum. So it's going to go up and end in those couple different regions depending on what kind of information is carrying on what pathway. This is a picture from that same book with that Donna dermatome. This is it's pretty cool. Actually, it's kind of cool. I need to hang that over. I think my wife would let me hang that over the fireplace. It's pretty nice black and white just over that. It would go with the gray and everything in there. So I'm not sure I could pull that off, but just showing you. It's kind of abstract there a little bit. So what do you need to know about all these 11 fun pathways? Basically, the key things you want to know about every one of these is what kind of sensation does it carry? What's the modality it's carrying? Does it cross the midline of your nervous system? Does it go from one side to the other? Does it cross? If so, where does it cross? Okay. And then how will a patient present if you have damage to that particular pathway? What kind of symptoms will they experience? And if the damage is in the spinal cord, versus the brainstem versus the cerebrum. Okay, so we'll talk about that as we go through, and we'll give you some case studies to work on and so forth. So here are the primary pathways through the spinal cord and brainstem and cerebrum for somatosensation. We have what's known as the conscious proprioceptive and discriminative touch pathway, which is collectively known as the dorsal column medial lemniscal system. Okay, dorsal column medial lemniscal system. We'll get into that, why it's called that. That's bringing in that conscious. I know I can feel it. I'm consciously aware of this information coming from my body, from my neck down. Okay, that's the dorsal column medial lemniscal system. Then we have that same thing for the head and face, which is the trigeminal tract that provides conscious proprioception from the head, face, mainly. Then we have a group of tracts that are carrying information called unconscious proprioception, stuff that never reaches our cerebrum, we're never consciously aware of. Collectively, those are all known as the spinocerebellar tracts. Then lastly, we have what's considered the pain, temperature, and coarse touch pathways. And we have what's considered the anterolateral system, which carries a bunch of tracts, the most important of which that you probably have maybe heard at one time in your undergrad is the spinothalamic tract. And that's carrying pain and temperature from the body. But we're going to talk about, in addition to the spinothalamic tract, which is really just the fast pain and temperature from the body, we'll talk about a number of other slow pain pathways, okay, that are all under that anterolateral system. You have the anterolateral system, and underneath that you have spinothalamic tract, spinal reticular tract, you have all these other, there's 4 pathways underneath that. And then you have a trigeminal thalamic tract, which is the pain temperature pathway for the head and face. Okay, so we are going to go into some detail on those. So we're going to kind of, I think, go through them in this same order here. This is that little handout I showed you that breaks these things down to as basic as you can get. So starting on the left here, pain and temperature. So here's this little dashed line. That's the center axis of your central nervous system, left versus right, okay? So just to give you, I'm just going to give you the overview so you know how to read this chart. So here's information coming in on one side of the nervous system, and it happens to come in the spinal cord, and it crosses over to the other side. So it comes in the spinal cord, and it crosses over. Where does it cross over? Right there in the spinal cord pretty immediately. And then it goes all the way up and eventually to the thalamus and the cerebral cortex. If you go to the thalamus, you're going to the cerebral cortex because you got to stop by the thalamus to get the cerebral cortex. So that's considered the spinothalamic tract. Okay, that's pain and temperature from the body, fast pain and temperature. Might want to qualify that. This is fast pain and temperature because we're going to talk about some divergent pathways that aren't represented here. But these are just the key ones. These are the key ones that everybody talks about that you learned maybe a little bit in undergrad or heard of. And then we've got proprioception, conscious. This is the dorsal column medial lemniscal system. So how does this thing go up? Here's our center of our nervous system. And then this line up here, this is our crossing point between the spinal cord and brainstem. That's what that line represents. So here it comes in on one side of the nervous system into the spinal cord. It goes up in the posterior columns, the dorsal columns or posterior columns. So you could put dorsal columns there. That's just the back part of the spinal cord. We'll point out these dorsal columns. It goes up in one of the dorsal columns. Depends if it's coming from your upper body or lower body. But anyway, just comes up. And then it crosses over. And where does it cross over? It crosses over right at the junction point between the spinal cord and the medulla. It actually crosses over in the medulla, but in the lower medulla, right that area there. So that's just showing you this is where the crossing point happens for this pathway. Comes in on one side, stays on that side, crosses over at the lower brainstem, and then up to the thalamus and the cerebral cortex. Got it? Here is light touch. This is showing you 2 pathways because it's actually carried on 2 pathways. Remember, light touch is carried on the dorsal column medial lemniscal system. That's fine light touch. So this is fine light. Well, I should say this is fine light touch to this one. This one here is coarse. Coarse light touch is carried on the spinal thalamic tract. That's where you just, yeah, I can tell you're touching my arm, but I can't tell you exactly where it's at. And that's just the same pathways we showed you before, just on this one. This is fine and coarse light touch being separated out here, fine and coarse. This conscious proprioception stereognosis, that's primarily coming from like things like some of your joint receptors and some of your muscle spindles and some of your other Pacinian specialized receptors that are telling you about position in space consciously. Then we have unconscious proprioception. It comes in one side of the spinal cord, one side of the nervous system, stays on that side, and ends in the cerebellum on that same side. So this is called an ipsilateral, where all these so far we've talked about here are all contra. So spinocerebellar pathways are unique in that they're ipsilateral in nature. They start on one side, stay on the same side, but they terminate in the cerebellum. They never make it up to the thalamus, or they never make it up to the cortex. Don't worry about this guy. This is motor tracts. This is motor system. So this is just a nice summary, very quickly, just to kind of see in a quick glance, what side does it come in? Where does it come in? Where does it cross? Does it make it up to the cortex or not? That kind of stuff. But I know you guys want to know a lot more than that, so that's what we get to do now, is go through the more detail of that, because you're doctoral, trained physical therapists. So we're going to go through these pathways in detail, take it step by step. So we're going to start with conscious proprioception, discriminative touch pathways, the dorsal column medial lemniscal system. So we're going to start at the receptor in this system. These are the types of receptors that it uses. This is the information that goes into this conscious proprioception originates by stimulation of these types of receptors. Okay? Combination of these receptors are being stimulated through pressure, touch, movement, whatever, to give you conscious awareness of what your body is doing in space. Okay? The types of modalities of sensation that this thing's carrying and transmitting is like pressure touch, which enables the awareness of the shape, size, and texture of objects. Kinesthesia, awareness of your body movement and limbs, being able to say, close your eyes, which way am I bending your arm? Up, down, that kind of stuff. That's kinesthesia. Weight, perception of weight of an object, conscious perception of weight of an object. Wow, that's really heavy. I can tell that's a lot of tension in my arm and my muscle. Okay. Position sense, so once I'm in a new position, so kinesthesia is when you're actually moving, actually knowing which direction your body's moving while it's moving. Position sense is when you're just static. Proprioception is kind of like a catch-all for both kinesthesia, position sense, stereognosis. Kind of proprioception is a generic term that kind of includes all this stuff. But kinesthesia is actual movement awareness. Position sense, or static position sense, is just that static position of where my body is relative to each other in a static position. Then stereognosis is the ability to determine the three-dimensionality of an object, to be able to tell how the shape of that object, what it is. And there's a certain region in your brain you need to be able to then identify that object, give it meaning, which is different than it. You can have stereognosis and be able to feel kind of like, oh, it's about this big, it's got a flat surface here, it's got a sharp surface down here, but I don't know what it is, and if you have a certain damage to a certain region in your brain, you can't do that, that identification, but you can still have normal sensation but not be able to identify the object. So when we can test for that, there's a test you do where you put common objects in people's hands, and you close their eyes, and you see if they may be able, you might have done all like the proprioceptive test, sharp dull, it's all fine, but they can't do stereognosis because there's another little region of their brain that interprets that to tell you that gives you meaning to that sensation. So, so I did use some of your pictures from your Lundy Ekman here, so to give you guys a little better appreciation and use those pictures as I trace this up. Um, so here's a general rule. If the pathway, if it's a sensory pathway, and if it's going to make it to your cerebral cortex, if it's going to go to conscious awareness, pain and temperature, conscious proprioception, it's going to have 3 neurons in the pathway. It's going to have a first order, second order, and third order neuron in the pathway. It's going to take 3 neurons to get it up to your cortex. If it stops in the brainstem or stops in the cerebellum, it's only going to have 2 neurons in the pathway. Okay? So this is the dorsal column medial lemniscal system that's going to conscious proprioception. So it's going to have 3 neurons in the pathway to get it up there. Okay? So we're going to start and talk about each neuron in the pathway. Where does it start? Where does it terminate? Where does the next one start? Where does it terminate? So the first order neuron is the one that's going to bring it from your peripheral. You stimulated a Pacinian corpuscle, a Meissner corpuscle, or something like that, and now you've got the information coming on that axon. The cell bodies for that first order neuron, that first peripheral nerve, the cell bodies are going to be in the dorsal root ganglion. So let's start with the leg. Here's a foot down here. This is that dorsal root ganglion. There's the cell body for the first order neuron for neurons in this pathway that are coming from the leg. Okay. Then we also have ones, here's from the arm that's coming in to the cervical spine. So let's orient ourselves. Here's lumbar cord. So we're seeing these horizontal cross sections through lumbar, cervical, lower medulla, upper medulla, pons, and midbrain. And that's what you're going to see. And also that picture here is a similar kind of setup. Low medulla, mid medulla, pons, midbrain. That's where people usually make these cross sections. That enters, the first order neuron enters the spinal cord through the medial division of the dorsal root. So the dorsal root's right here, and I'll show you a close-up picture of what we mean by the medial division of that dorsal root. Then it's going to come in, and it's going to go up the back part of the spinal cord. And this is still, it hasn't made a synapse yet here, right? It comes in, and it goes right into the back door of the spinal cord and right up the backside of the spinal cord with that central axon. This is the peripheral axon out here, which is going to be one of those 1As, 1Bs, 2s, A betas. It's going to be one of those faster transmitting. Could be anything but a C or A delta fiber, essentially, is what's transmitting that. That's the peripheral axon. Then this is the central axon. There's our dorsal root and the cell body. Then the central axon comes in and starts to go up the back part of the spinal cord. Okay? And it ascends in one of 2 columns called the posterior dorsal columns. Okay, so it ascends up there. If it's coming from the lower body, it's going to go up as the fasciculus gracilis. So it ascends in the posterior funiculus as either the fasciculus gracilis. If that axon enters anywhere from your body below T6, it's going to ascend as part of what we call the fasciculus gracilis, which is one of your posterior columns. If it's coming in from your upper body anywhere above T6, it's going to ascend in what's called the posterior column called the fasciculus cuneatus and go up to the medulla. Where in the medulla, it's going to then have its first synapse. So the first order neuron is going to synapse with the second order neuron in that lower medulla at the nucleus gracilis or the nucleus cuneatus. And that makes sense because that corresponds to those dorsal columns, the fasciculus gracilis and fasciculus cuneatus. Okay. So that's this right here. There's the synapses occurring right there. So the ascending up in these dorsal column region back here, then to go and make their first synapse with their next neuron in this 3 neuron sequence in the lower medulla. in that little region. There's a little nuclei, groups of cell bodies in that nucleus gracilis and nucleus cuneatus. So now we're at the second order neuron, and the cell bodies are in that nucleus gracilis and cuneatus. Those axons from those cell bodies are going to immediately cross. Those axons are going to project and cross over. That's these guys right here. They're crossing over and crossing over at the low medulla. So that's the decussation point. That's the crossing point for the medial lemniscal dorsal column system, is at the low medulla, and that's called the lemniscal decussation. Lemniscal decussation. That's the desiccation is the crossing point. And the little fibers, they're called there, these little fibers here, they're called the internal arcuate fibers. They're kind of arcing, you know, to cross over. They're called the internal arcuate fibers. The actual crossing point, because remember you have the other sides crossing here, this crossing point, that's the lemniscal decussation. Because then once it crosses over, kind of like street names in Dayton, they change names once you cross over or once you get to another region. So once you cross over here, so they're ascending, the first order neurons are ascending up the back part of the spinal cord as the dorsal columns, fasciculus gracilis, fasciculus cuneatus. They make the synapse with the nucleus cuneatus and gracilis. They axons cross over, and now when they go up on the other side, now they're called the medial lemniscus. So they change names from dorsal columns to medial lemniscus. And a lemniscus is a flat ribbon-like, kind of like, and you'll notice as it goes up, and we'll show you cross sections of this in a second here, it kind of, the arrangement of the axons kind of flattens out, gets a little more ribbon-like, flattens out, and it kind of twists as it goes up through your brainstem and towards your thalamus. Okay, so kind of like this twisting ribbon. So ascends the brainstem as the medial lemniscus. So all through here, 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 here. This is all considered medial lemniscus. Once you're in that, once it's crossed over, it's now the medial lemniscus. Then those second order neurons are eventually going to synapse here in the thalamus. And they're going to synapse in a specific region of the thalamus called the ventral posterolateral nucleus of the thalamus, the VPL, ventral posterolateral nucleus. Then that's where the third order neuron starts. So it's going to synapse in the VPL, and then the cell bodies of the third order neurons are located in the VPL, and then they're going to project up to the cortex via the posterior limb of the internal capsule. This is the internal capsule. This is the area of white matter where these axons are traversing through the cerebrum, called the internal capsule. You have both motor and sensory fibers that go through this internal capsule. There's a certain region of the internal capsule called the posterior limb of the internal capsule, where it just so happens that these conscious proprioceptive axons are traveling. And then they're going to go to the region of the cortex that represents the part of the body they're going to. This would actually be leg over here that goes to the medial surface of the cerebrum. We'd have face down here, hand right in this region. Okay, so it's going to go to, there's a what we call the homunculus. There's a certain region of the cerebral cortex that represents a certain region of your body. So it's going to deliver that message to that region of the cerebral cortex. And that particular primary somatosensory area is on the postcentral gyrus of the cerebral cortex. Remember we showed you that postcentral gyrus, that first gyrus just back behind the central sulcus. That's where the primary sensory information is going to go. Yeah.
Those pictures with like the weird funny faces that represent the homunculus, are
Yeah.
those pretty accurate?
Yeah. And so the homunculus, if you've seen it, it's also, the pictures are proportional to the amount of real estate it's taking up. And, you know, so you'll see a big face and a big hand because there's so much more sensory information coming in your face and your hand. You see a little leg, a little tiny torso, because there's not much. Remember that there's these big superficial like receptive fields that you don't have hardly any neurons bringing in that much sensory information from certain regions and more from others. Yeah.
And that's all in that sensory cortex?
Yep, it's all on that sensory cortex. Yep, on that little strip, that postcentral gyrus. Yep. Where you?
Just to clarify these pictures, the three neurons that are involved with the pathways that make it to the cortex, those aren't related to the three colors
No.
Those
Good.
are
Yeah, those three colors are representing from different regions of the body. Yeah. So like this one and this one, those are both first order neurons. All three of those that are in here, these are all second order neurons. There's not three. There's three here because now you've added the face. This is the trigeminal tract. But and so those are, and then these all here are third order neurons that are coming just from different parts of the body. This is like a little more of a color coded look at it. These are cross sections to those same regions, and just shows you like here is, the blue is coming in from the lower body. This is L4 coming in, and it comes in to the back part of the spinal cord. And then once you get above, remember, um, above T6, so here's showing some information coming in from a T4 right here. That's when you add on. So this blue is fasciculus gracilis. The reddish is fasciculus cuneatus. That makes up your dorsal columns. And then here is the nucleus cuneatus and nucleus gracilis up here. And then once they cross over, they get in this more arrangement in the low medulla and mid medulla. They're arranged in this anterior posterior direction. They're more thin and narrow, but lined up in this anterior posterior direction. But you'll notice once we get up into the pons, notice how it's twisted. It actually goes up and twists into more of a medial lateral arrangement of those fibers. And you'll see kind of how the somatotopically, the way they're laying in there is, here when they first cross over, the proprioceptive information coming from the lower body is more anterior, and from the upper body is more posterior. Then as it swings up into the pons, now the lower body information is more lateral and the upper body is more medial. And then it continues to twist even as it gets up into the midbrain right here, and it gets more into this anterior posterior arrangement again. But now we've got this upper body is more anterior medial and the lower body is more posterior lateral. And then this is the thalamus right here, and this is that VPL. And there's a certain region of the VPL that upper and lower body information goes to. So you've got this somatotopic arrangement that's maintained all the way up. There's parts of this column of axons that you can distinctly say this is more upper, this is more lower body, and then face gets added in there too. This is not showing face getting added in there. And then it's going to go to that specific region of the cerebral cortex that represents upper and lower body on the homunculus on that postcentral gyrus. So remember I mentioned that those first order neurons, they come in the back part of the spinal cord through the dorsal root, and we mentioned they come in via the medial division of the dorsal root. So here's your dorsal root, and it's divided into a medial group and a lateral group. So as that's coming in, the types of fibers that come in, the medial group here is your 1As, A betas. These are your muscle spindles, Pacinian corpuscles. This is the proprioceptive information that comes in a little more medial in that dorsal root because it's going to go up into the dorsal columns, which are more medial right there. The A deltas and Cs, the pain fibers, they come in a little more, this is lateral, this is more medial and this is more lateral, so that's why it's medial and lateral. They come in a little more lateral because they're going to go right in, they're actually going to synapse right away in this dorsal horn. So the conscious proprioceptive fibers we've been talking about, they initially come in this medial division of the dorsal root because they're going to go right into the dorsal column, and the axons are going to go right up there before they go up and synapse all the way up in the medulla. So this is showing you some different cross-sectional levels here. So this is a spinal cord cross-section here. Let me just change this to yellow. This whole region is called the posterior funiculus, right? This is the lateral funiculus over here. This is the anterior funiculus. Remember, a funiculus is a big region where there might be other pathways running in. So we're focusing right now on the posterior funiculus, which this is definitely above T6 because what we're seeing here, we have two dorsal columns here. So our dorsal columns are right here, and actually there's a separation right there. So if we just look at one side of the spinal cord, this more lateral area, this is fasciculus cuneatus, and this is more fasciculus gracilis. And I think of fasciculus gracilis because it's coming from the gracilis muscles in my legs. That's how I remember that's lower body. Then I just remember cuneatus has got to be upper body, right? And what happens is, so from the lower body, that dorsal column's coming up, and then all that happens is now the upper body information gets layered on top of it to the outside of it and just gets added on. So that's why it's more lateral as it gets added on. So this is all lower, and this is upper body information. Down in the lumbar spine, down in below T6, all we have is a fasciculus gracilis. It's not till you get above T6 that you have both the fasciculus gracilis and fasciculus cuneatus, because that's when you start adding on enough upper body stuff that it separates into two dorsal columns. So you have a single column down in the lumbar spine, then you have two columns on each side once you get up into the thoracic, upper thoracic, and this is the cross section through the decussation, the lemniscal decussation, the lower medulla here. This is actually nucleus cuneatus, and this is nucleus gracilis right here. The way these get stained is actually nuclei look lighter, where the axons look darker because the stain they use is specific to myelin, and the myelin absorbs the stain. So it's like a reverse negative. It's like a negative image. Okay, so when you look at these cross sections, lighter material is actually the white matter. Darker, the lighter material is the nuclei, the cell bodies. The darker material, the darker stained things are the white matter. Okay. And these are actually this area right around here. That's actually the remnants of your dorsal column. That's the fasciculus cuneatus. Those neurons, those axons are coming up, and they're going to terminate and connect with these cell bodies in the nucleus cuneatus. So this whole region here is the fasciculus cuneatus. It's the ending of this fasciculus here, but now it's terminating here, and its axons are going to synapse on the cell body. And then this region right here, this is the fasciculus gracilis at the end of it, and then its axons are going to stop there and communicate with the cell body here. Then these guys are going to send that across to the other side like this. This is the internal arcuate fibers, as they're called, internal arcuate fibers, as they're arcing across to go across the other side. And then remember, we have the same thing happening over here. These fibers are crossing over here. So this crossing point, that's the lemniscal decussation, the decussation of the medial or lemniscal decussation. Let's just call it that. But these guys are going to come over here, and then they're going to, this is the medial lemniscus. The beginning of the medial lemniscus is right here in the medulla. Once that second order neuron crosses over, and now those axons start to go up in the medial lemniscus. And they maintain that somatotopic arrangement that I'm showing here with where upper body versus lower body is arranged more in this anterior to posterior direction. And then that thing goes up and just starts twisting as it goes up through the brainstem. This is actually the medial lemniscus right up here. This is a cross section. You'll start to recognize this almost butterfly-looking cross section. This is through the midbrain. And this dark area, which is the axons, because this is the myelin stain, that's the medial lemniscus right there. After it's gone up and twisted all the way around, it's going up through the brainstem. This first pathway takes us the longest because we're going through and we're highlighting all these different reference points, and so when we start talking about the rest of the pathways, you already know we're like, oh, that cross section is this, and these are this. So this first one, we just spend a lot of time orienting you to what you're seeing, and then the next ones that come a little faster, maybe easier, I don't Um, remember, now looking at the backside, the external surface of the brainstem, remember we showed you this. Now we can see here. So this is that transition point between spinal cord and this is, low medulla in here. And so here is a couple columns coming up the back. Here's your dorsal columns. There's a column here. This column is coming up here. Then there's a bump right here. So this column is this more lateral column is the fasciculus cuneatus that's been added on. And so like we cross-sectioned and look right beneath that, that's where those axons are running. If we did a horizontal cross-section there and look down, that's where the axons are running from the upper body. Proprioceptive information is coming up there. Then there's this little bump right here, and if we looked right deep to that bump, that's where the nucleus cuneatus is, right underneath that bump. That's where that first order neuron is going to make that synapse before it crosses over. And then here, oops, more medial, we have this column coming up, and then a bump right there, and that's going to be our fasciculus gracilis. And then this is our gracile tubercle, which just underneath the tubercle is the gracile nucleus. So yeah, I should have said that's the tubercle. These are the tubercles when you're looking at the surface, the outside. But underneath those tubercles, there's where the nuclei are lying. You only see the nuclei if you see them in a horizontal cross-section. This is an external feature we're looking at. So it's the gracile and cuneate tubercles. It is still called the fasciculus gracilis and fasciculus cuneatus here, which is a little bit confusing. But from the outside, it's called those as well. And also in the cross-section when you're looking at the dorsal columns. I want to erase. Can't get it to erase. Oh well. So here's that little chart, and we'll just demonstrate how to use this real quickly with this drawing this out, and we'll do like maybe 3 different colors of pen to do this. So let's do lower body proprioception. So let's draw a little specialized receptor out here. Okay. So we've got division here. We've got lumbar, cervical, then we've got medulla, pons, midbrain. So I've got this divided up into little, into the different regions. It comes in. We've got a cell body right here, okay? That's our DRG, right? This axon right here is going to be, this could probably be an A beta or a type 2. I don't know. It could be any one of those more fast, depending on what this receptor is. Okay, so it's just definitely not going to be. It's not going to be a C or A delta. It could be any one of those. So it's going to come in to the spinal cord, and it's going to come in the dorsal root, and more specifically the medial division of the dorsal root, and it's going to go in and start going up the same side of the nervous system, same side of the spinal cord it came in on, right? Stays on that same side, and it's going to do that. And that little area is called the fasciculus gracilis, right? Because this is coming from the lower body, and it's just going to stay that way all the way up through the spinal cord. And it's going to get into the medulla. And this is where it's going to do something, right? And it's going to cross over in the low medulla. So I'm going to keep this little connection here in the low medulla. And now we'll go to the second order neuron. Let's make it blue. So the cell body for that second order neuron lies in the nucleus gracilis, right? And then it's going to immediately cross over to the other side of the nervous system right here. Okay. If we want to, we can call those the internal arcuate fibers. They cross over. And now they start ascending through the pons, midbrain, and it's twisting as it goes, and it's ascending in this region all the way up through there as the medial lemniscus. And then this is our thalamus right here, and I've got it basically just divided into two things: a lateral, which we're going to call our ventroposter VPL, and then the other one's a VPM, which we'll get to when we get to the head. The VPM, all the stuff from your head goes to the VPM. So, and let's go here. Let's go green. It's going to go up, and it's going to synapse with a third order neuron, which is in the VPL, ventroposterolateral nucleus. And because this is a leg, the leg representation is right over here. It's actually on the medial surface of your cerebrum, of the homunculus. It's on the medial surface, if we want to get real specific here. This is all this. It passes through this white matter region called the internal capsule, and then this is the postcentral gyrus. Postcentral gyrus in the region where the leg is. Got it? Makes sense? Kind of like all the stops, all the major locations and names and those kind of things. That's for just the, then we could do the same thing for the cervical, you know, which would be the same. It'd just be the fasciculus cuneatus and nucleus cuneatus, but everything else is the same. It'd just be that, and they just come in. It'd be coming in here in the cervical region, you know, or upper thoracic cervical region. Okay. So now let's talk about the trigeminal pathway. This is the head equivalent of the dorsal column medial lemniscal system for the body. It's going up to the cortex, so it's going to have 3 orders of neurons. This is conscious awareness of proprioception of your head and face. Here, if it's coming from your face, right there, so this is coming from the left side of the face. It's going in to the trigeminal nerve, a cranial nerve, which is just a peripheral nerve. It's coming from our face. Here's the cell body in the trigeminal nerve ganglion, which is kind of the equivalent of our dorsal root ganglion in our spinal cord, but this is for the trigeminal nerve itself, because it's a peripheral nerve, so its cell body's outside before it gets into the brainstem. So that's the first order neuron. Then what it does is second order neuron cell bodies are located in what's called the trigeminal main sensory nucleus. The trigeminal nerve has a nucleus associated with it, but it's broken into like 3 different parts, and we'll talk about it. There's a certain region of the trigeminal nerve nucleus that receives conscious proprioception. It's just called the main sensory nucleus of the trigeminal nerve, so the main sensory nucleus. And then the axons then immediately cross over in midline, cross the midline, and ascend in the trigeminal lemniscus. The trigeminal lemniscus is actually just a little subpart of your medial lemniscus. That's your medial lemniscus. They just add their fibers on to the medial lemniscus, but as a separate little component called the trigeminal lemniscus. So it just is separate. It's right next to it's right at the tip of the medial lemniscus, right on the edge of the medial lemniscus as the trigeminal lemniscus, but it runs right with the medial lemniscus at that point. Kind of joins up with the medial lemniscus. As the medial lemniscus is ascending, then the face just kind of go boop and adds on to the end of or edge of it. Okay. And then it just goes up through the brainstem. Here's the midbrain. This is the medial lemniscus, but the trigeminal lemniscus is this little component, little end on it. And then it goes up to not the VPL, it goes to the VPM. It goes to a little more medial location in the thalamus. I think VPL, I think leg. L is leg for me to remember body. And I think VPM is like masseter, masticate. So that's why I think VPM is always face stuff. So if you're coming from the face and you're going to go up to the cortex, you're going to stop at the VPM. And then the third order neuron, in this case, it would go down here to the facial region of the homunculus here, which is down this. It's the postcentral gyrus. Still passes through the internal capsule, but it's going to go to where the facial area is, represented on your cortex. Make sense? So that's the trigeminal pathway. That's how conscious proprioception gets from your head and face there. This is just showing you, these are actually, so this in blue here, this in blue, and this in blue, all three of those are sensory nuclei for your trigeminal nerve. Your trigeminal nerve is a massive nerve. You have lots of information, sensory information coming from your face, and then it does have a motor component, but the one that it goes to that for proprioception is this one right here, the main sensory nucleus. When we get to cranial nerves, we'll go into all that more detail, but the main sensory nucleus receives the conscious proprioceptive information. That's where those second order neuron cell bodies lie. Yeah.
Is that why when people have that trigeminal neuralgia?
Yes. Yes, and actually, see this big, huge, long cell nucleus? That's the spinal nucleus of cranial nerve number 5. It actually goes all the way down into your spinal cord for your upper cervical, even down to like C4. That's for pain reception of the face. You have massive pain receptors in your face. And that's why trigeminal neuralgia and facial pain is one of the worst pains you can have, and it's almost intractable. Actually, normal opiates and so forth don't help trigeminal neuralgia. You almost have to take like anti-epileptic type of, or like Neurontin, anti-seizure medication to try to calm that down. Sometimes it's better than opiates. Break time. One more break here before we So, all right, so we talked about conscious for body, head. Now we're moving into unconscious proprioception for body. And they really don't talk about it for the head, but there's an unconscious proprioceptive pathway for your face too. But we're going to talk about those, which collectively are known as the spinocerebellar. So some of the names help you and know where things are located, where they're starting or finishing. And so dorsal column, back of the spinal cord, and then it turns into the medial meniscal, a little more flattened, but anyway, and it changes names in the brainstem. Spinocerebellar tract. If it says spinocerebellar, starts in the spinal cord, stops in the cerebellum. Spinocerebellar. We have four spinocerebellar pathways. 2 are considered the high fidelity, means like really fine information, fast information from discrete regions of our joints and ligaments and tendons and muscles. 2 high fidelity pathways that are bringing in unconscious proprioception from peripheral receptors in our muscles and ligaments and joints from our upper and lower body. Okay, the posterior spinocerebellar pathway, which is bringing from the lower extremities, and the cuneocerebellar pathway for the upper extremities. Remember, we had the cuneate, the fasciculus. I get tongue-tied with some of the stuff. So the fasciculus cuneatus is from conscious proprioception. The cuneocerebellar is unconscious proprioception from the upper body. So you just got to remember that the posterior spinocerebellar would be from the legs. Okay, that's bringing up that information from those peripheral receptors that are going to go to your cerebellum. We have 2 internal tracts. That means they don't have any direct connection with peripheral receptors. They're actually monitoring. They start and stop within the central nervous system. They start actually in the spinal cord and stop in the cerebellum, and they're monitoring interneuron activity at the spinal cord itself. They're monitoring information that's coming into the spinal cord from those other 2 pathways, plus some motor tract information coming down. That's all coming together at a certain location in the spinal region, and they're monitoring the interneuronal activity of both motor and sensory information coming in, and they're sending that information from what's happening right at that spinal cord level back to the cerebellum. Those are the internal feedback tracts or pathways. One is the anterior spinocerebellar tract, that's from the lower extremities, and then the rostrospinocerebellar tract, rostral, more rostral, upper body. So remember the posterior spinocerebellar and anterior, both lower body, but one is more of an internal feedback loop. One is bringing it in from the actual receptors. And we'll show it in pictures. Pictures for me on this stuff are always better. So we're going to start with the posterior spinocerebellar pathway. The receptors, muscle spindles, GTOs, and all those joint receptors, all type 1 through 4, all of those can contribute information into this pathway, are going to be stimulated. And those are going to be sending the afferent. And also, this is not going to the to the cerebrum. It doesn't have to go to the thalamus and then the cerebrum. So it's stopping in the cerebellum. If it's going to stop just in the cerebellum or in the brainstem, this is the cerebellum, just 2 neurons in the pathway, which makes it a little easier. You only think about 2 neurons. Modalities is your posturing, maintaining normal postures and also movement of the lower extremities. I should say upper extremities too. I don't know why it just says lower extremities, but unconscious. This is posterior spinocerebellar pathway. That's why it says lower extremities. This is just the posterior. So here it is. We just have a first order and a second order neuron in this pathway. So here is a muscle. Why is it not writing? Right, there we go. Muscle spindle, little squiggly muscle spindle here. That's maybe what annulospiral fiber wrapping around a nuclear bag fiber. I don't know. So anyway, it sends a signal to the spinal cord. Cell body is in the dorsal root ganglion. Just like all those other cell bodies for any other modality of sensation. Pain, temperature, conscious proprioception, they're all coming in the same way. It enters the spinal cord also through the medial division of the dorsal root. It makes its first synapse in the nucleus dorsalis, which is also known as Clark's nucleus. Clark's nucleus only extends from T1 to L3. Clark's nucleus is this little region of gray matter within the dorsal horn in that T1 to L3 region is where that Clark's nucleus is. It's in that gray matter anywhere in that L1 to T3 region. So if you have lower body information coming in from below L3, like L5, S1, it actually goes up the fasciculus gracilis for a little bit before it then synapses with Clark's nucleus. But you don't have to know quite that detail. But just first synapse for the posterior spinocerebellar tract is in Clark's nucleus, or the nucleus dorsalis, and that's only from L3 to T1. Okay, just in this region here. It makes a synapse. And then the second order neuron, as soon as that axon just projects laterally into this little region on the lateral funiculus. This whole region out here is the lateral funiculus of the spinal cord. In a region of the lateral funiculus, it then ascends in the posterior spinocerebellar tract. So once it gets out here, it just goes up and it stays in that posterior spinocerebellar tract all the way up through the spinal cord and into the brainstem, never changes names. Then it enters the ipsilateral. So remember, this stays on the same side. It enters the same side, ipsilateral side of the cerebellum via the inferior cerebellar peduncle. Remember, we had those different connecting stalks. We had a superior cerebellar peduncle, a middle, and an inferior. Well, the spinocerebellar pathways, most of them get in through most of them, not all of them, most of them get in through the inferior cerebellar peduncle because they're coming up from below. So they kind of come in, the closest one is to go through the inferior cerebellar peduncle. And then terminates in the cortex of the cerebellum. Not cerebrum, cerebellum. And it's all staying on the same side. Ipsilateral pathway. This is just showing you a cross-section through a spinal cord. This side here shows you there's different types of cells located in these laminal areas. These are called rhexis laminas. There's 10 rhexis laminas. But there's also these distinct regions. Some of these regions cross over multiple rhexid laminas that are nuclei, that are distinct nuclei that are located within that gray matter. So there's this laminar structure, but then there's also nuclei that are kind of populating, superimposed through this that may not fit into a specific lamina. Okay, and one of those nuclei is Clark's nucleus, or the nucleus dorsalis, which is this guy right here. That's where Clark's nucleus. So Clark's nucleus is kind of right in this region here, crosses over between regions 6 and 7, but that's where, and that Clark's nucleus, you'll only find it between L1 and T3. And so if you come in from lower than L1, you got to go up to L1 before you make that connection. But if you come in, somewhere between L1 and T3, you're going to go in and right away and make that connection. So that was the posterior spinocerebellar. Now we have the cuneocerebellar, which is the upper body information that's coming from muscle spindles, Golgi tendon organs, joint receptors, the same types of sensation, unconscious. Here it is. So here's a little muscle spindle in a bicep. Here's the first order neuron, cell body in the dorsal root ganglion. It comes in, it enters the spinal cord through the medial division of the dorsal root, just like everything else we talked about. It just goes into the fasciculus cuneatus. It joins up with the fasciculus cuneatus at this point. And then it ascends, because it's up into the lower medulla, and it synapses in a nucleus that's lateral to, this is right here, this is the nucleus gracilis, this is the nucleus cuneatus. Then there's another nucleus out here called the lateral cuneate nucleus, because it's lateral to the cuneate nucleus. And that nucleus is where that synapse is, that synapse between the first order neuron, the cuneocerebellar tract, and the second order neuron in the cuneocerebellar tract. And it's right there in that same region, the lower medulla. So it makes that synapse right there. So it synapses in the lateral cuneate nucleus. Then it ascends through the posterior medulla as the cuneocerebellar tract. So it's just ascending in the back part of the medulla and the back part of the spinal column or brainstem as the cuneocerebellar tract. You really can't identify it in cross sections. It's just too small of a tract, and you can't really identify it in cross sections once you get beyond that. But just running up the back of that, okay? It enters the ipsilateral side also of the cerebellum via that inferior cerebellar peduncle. So it enters in through the inferior cerebellar peduncle, just like the posterior spinocerebellar tract did, and terminates in the cortex, ipsilateral cortex of the cerebellum. See that you're getting fast. Easy. You know all the terminology now? So I'll give you a week to start getting the terminology down. So now, those are the two high-fidelity spinocerebellar tracts that are bringing in the actual information from the peripheral sensors. We have two spinocerebellar tracts that are just internal feedback tracts. These are ones that don't have direct receptors associated with them. So receptors is non-applicable, okay? They are monitoring activity of spinal interneurons at each spinal level. So they're monitoring the activity of both descending motor signals going down to a certain spinal level and incoming proprioceptive signals from your other posterior cuneocerebellar spinal tracts. They're monitoring that and saying, here's the information coming in that's telling us what's happening in the environment. Here's the signal that's coming down to tell us how to interact with the environment. Do those signals, are they matching? Is there appropriate match between those signals? We're going to monitor that activity and send a signal back up to the cerebellum to help assist and modulate the interneuronal activity so that we can help fine-tune the next signal coming down the pike and help fine-tune it right at the spinal cord level. Okay. Um, and when we get, we'll have a whole lecture on the cerebellum, and we'll go into a little more detail on how this all occurs and this feedback that's provided here. So they're monitoring activity of exactly what's happening moment to moment, right where everything is coming down from the motor system and coming in, and then telling that back to the cerebellum to give additional information to the cerebellum of what's happening from a motor and sensory information to just supplement the other information coming from the peripheral receptors. Okay. We're going to skip this and just go to this anterior spinocerebellar tract. So here's the cell bodies for this originate in the gray matter of lamina number 7 in the thoracolumbar spinal region, okay, which is right around kind of that Clark's nucleus area. Remember we were near kind of that lamina number 7? Remember when we went back? This is lamina number, let me erase. This is lamina number 7 right here. So it's in this region right near Clark's nucleus area. So that's where it's kind of monitored. The cell bodies start there. This is for, remember, anterior spinocerebellar. This is the internal feedback pathway for the lower body. That's why it's near Clark's nucleus. It's right there where all that information is coming in. So cell bodies are here. Lamina number 7 right here. There's Clark's nucleus, but they're all really close to each other. So that's the internal, starting there. This is really, I wish it didn't do this, but it does because it just likes to make it confusing. Those cell bodies project an axon that immediately crosses over in the anterior white commissure. There's a little thing called the anterior white commissure. There's a little bit of white matter right in the front of the spinal cord, right there. That's a crossing point for this pathway. It crosses over the anterior white commissure, and the axon projects over and then into what's called the anterior spinocerebellar tract. And it goes up as the anterior spinocerebellar tract all the way through the spinal cord and the brainstem, stays that same name. And we noticed, remember I said most of these pathways that come from the spinal cord go in through the inferior, cerebellar peduncle. This one goes through the superior cerebellar peduncle. And before it does, it crosses back over to the same side. So even though it starts on this side, it crosses over, it recrosses back over. So if you start and stop on the same side, you're still in ipsilateral tract because it crossed twice. Crossed over, goes in through the superior cerebellar peduncle, drops back down, but still ipsilateral, still delivering information from one side of your body, from the left side in this case, to the left side of the cerebellum. Still follows the rule of ipsilateral. And terminates in the cortex. Then the rostrospinocerebellar tract is the other internal feedback, and this is for the upper body internal feedback. Rostro is more upper body, rostral is more towards the beak. Again, it does the same thing of monitoring activity of spinal interneurons and then comparing the motor output with the incoming sensory input and then delivering that message to the cerebellum. So again, cell bodies are in the gray matter of lamina number 7. However, in the cervical, right there, cervical spinal cord. It ascends in the posterior medulla. Just goes right up the back part of the spinal cord and the posterior medulla as the rostrospinocerebellar tract. You can't even identify it on cross sections. We don't even try to identify it on cross sections. And it enters the ipsilateral cerebellum via both the inferior cerebellar peduncle and the superior cerebellar peduncle. So it comes up, some of those fibers go in here, some go up to the superior cerebellar. That's not that clinically relevant, to be honest with you. It's still an ipsilateral tract, okay? It's still, all the tracts we've talked about, the cerebellum, one side of the body goes to the same side of the cerebellum. And all that means when we get to clinical and lesions, if you have damage to the left side of your cerebellum, you're going to have incoordination on the left side of your body. So All right, we're doing well here. So we're going to do pain and temperature and coarse touch and finish up after this. This is the anterolateral system slash spinothalamic tract. I think we'll just get through the main, this one and then take a break. Or be done for the day. Just get through the spinothalamic tract. Then we'll talk about the divergent pathways tomorrow. This is not how you want to test somebody with peripheral neuropathy. Just see where their pain starts. So the anterolateral system includes. So this whole system can include all these pathways: the spinothalamic, spinal limbic, spinal mesencephalic, spinal reticular. We're going to just probably do this one right now, spinothalamic, which is the fast pain and temperature from discrete regions of your body. All the rest of these are all these slow aching pathways or divergent pathways because they go to lots of divergent areas in your nervous system. So spinothalamic, starting with the receptors out in your periphery. Let's go lower body here. Non-encapsulated free nerve endings. Your free nerve endings are what's going to cause the pain stimulus. It's going to be carried on a C fiber, A delta fiber, right? These fibers here are going to be, actually this is fast pain, so this is A delta. I forget how you write a delta sign. Here you go, L delta's right there. I can't write A delta. So fast pain. First order neurons, cell bodies, dorsal root ganglion, just like everything else. It's going to enter the dorsal root, but via the lateral division of the dorsal root. Lateral division of the dorsal root. It's actually, even though it shows it making an immediate synapse here and crossing over, what really occurs is it goes in and it goes in this little tract called the dorsal lateral tract of Lissauer, or Lissauer's tract. It goes, and it might go up or down a few spinal segments before it makes its connection. And so when you're testing pain and temperature in a spinal cord injury patient, there's usually some overlap of segments, and it's also like, so it's like, even though their spinal cord injury level is a certain level, you might find that a segment or two below, they still have it because it ascends and descends a little bit, those pathways. It might make it around the injury a little bit. So just understand that even though we technically consider that immediately once it comes into your spinal cord, it crosses over, it makes a connection and crosses over, it actually goes in and goes up and down a little bit in this dorsal lateral tract of Lissauer before it makes that connection. So the second order neuron is in the dorsal horn in a region called the substantia gelatinosa, which is mainly lamina 2 is mainly contained in lamina 2 of those Rex's laminas, but it extends a little bit into lamina 1 and 5 as well, that substantia gelatinosa. Kind of like I have Clark's nucleus for that unconscious proprioception in that. This is called the substantia gelatinosa. That's a nuclear region that's in the spinal cord gray matter that extends across a few of these laminar levels. So then the second order neuron, so here, let's just show you some of that here. So here's our dorsal root ganglion. What is in red is pain and temperature. It comes in, makes that synapse. It usually goes up or down a few levels first, but then it makes a synapse pretty quickly in the dorsal horn here. And then it crosses over in this little tiny white matter region. This is the anterior white commissure. That axon projects over, then it goes out here into the spinothalamic tract to go to ascend up the opposite side of the spinal cord. So the crossing is happening immediately here, or within a few levels. Okay. And this is coming in that more lateral division. This is more lateral division of that dorsal root, because it's going to go over here to that dorsal horn versus the other proprioceptives coming in more medially. So this is the lateral division of the dorsal root. And then this whole region right here, this is considered the substantia gelatinosa. This is where the cell bodies lie for those second order neurons and pain and temperature pathways. You can see that this is lamina 2, but it also extends a little bit into lamina 1, and then lamina 5 is down here. It actually has, it extends through that, and a little bit of region in lamina 5 is also used. Some cell bodies for it are also in lamina 5, but so then the second order neuron it's in lamina 1, 2, and 5, substantia gelatinosa. Substantia gelatinosa. It desiccates or crosses in the anterior white commissure and then becomes the spinothalamic tract. It ascends the lateral brain stem. Once it gets to the brain stem, it also is called the lemniscus. Just like we had the medial lemniscus, this is called the spinal lemniscus. So once it gets into the brainstem, into the medulla here, it's called the spinal lemniscus. And it gets a little more flattened, it's not as round, or I don't know. It actually stays it's in the spinothalamic tract. It actually is kind of a little flattened too. It's just called a lemniscus once it gets into the brainstem. So it goes from spinothalamic tract to the spinal lemniscus. It goes to the VPL of the nucleus, so it goes to the same, if it's coming from the body, it goes to the same area that the conscious proprioception did. If it's going to go up to the cortex, it goes to the VPL, ventroposterolateral nucleus, okay? And then the cell bodies for those third order neurons then go to whatever region of the postcentral gyrus to deliver the pain and temperature in the postcentral gyrus. And it also goes through that same internal capsule region that your conscious proprioception fibers went to. So let's draw it out real quick and be done. So here's a foot down here. There's a nail or something we stepped on. Ouch. Free nerve endings. So free nerve ending. Axon comes in. Dorsal root ganglion here. This is A deltas. We'll just write delta. A delta fibers. Fast pain comes in. Synapses on the same side with the second order neuron. And that is in the substantia gelatinosa, right? Which is relatively layers 1, 2, and 5 of laminas. Crosses over pretty immediately, although this really kind of comes in and goes up and down a little bit, that first order neuron, but let's not worry about that at the moment. Crosses over in this is the AWC, anterior white commissure, and then goes and be up as the spinothalamic tract. Ascends as the spinothalamic tract all the way up the spinal cord. Once it hits the medulla, now it changes names, and now it's the spinal lemniscus. Goes up to the VPL of the thalamus. Synapses with that. And then goes, this is coming from the leg, so it's going to also go right over here. It's going to go over to the postcentral gyrus and homunculus that goes all the way over to the medial surface of the cerebrum and deliver that pain message, fast pain, up to that region. Got it? Make sense? So we're going to stop right there. I think that's plenty of tracks for one day. So your quiz tomorrow will be one of these guys with some little fill-in of identify, matching, identify something of these two pathways, the medial lemniscal dorsal column, spinal thalamic tract. Let it soak in. Don't freak out. It's actually, just once you've seen these pictures a few times and you just kind of start to group them together, use the names, and like some of the names help you tell where they started, where they stopped. So